Mpox is a highly infectious disease and now a global public health emergency. A little more than a year after COVID was declared over, several new threats are emerging. But how ready are we for another pandemic? Hello and welcome to Roundtable. I'm Enda Brady. Now, scientists are warning that it's only a matter of time before some new pathogen pushes the world back into a COVID-type situation. And there's a possibility the next one could be even worse. So, what lessons have been learnt from the last pandemic?
An estimated 7 million lives lost globally. Overwhelmed doctors and nurses. Lockdowns. Economies in ruins. The world would rather forget about the COVID pandemic, officially declared over in 2023. But now it faces other health threats, and scientists are warning that another pandemic is almost certainly on the horizon, for which we are definitely not prepared again.
History teaches us that outbreaks and pandemics are a fact of life. But when the next pandemic comes, the world must be ready, more ready than it was this time.
There have been several concerning outbreaks since the end of the COVID emergency. In August, the World Health Organization declared Mpox, a highly contagious disease, a global public health emergency. It started in the Democratic Republic of Congo, but it's since spread to 13 countries and killed over 500 people in Africa this year. Also of concern is avian flu, the H5N1 virus that originated in birds. And more recently, the resurgence of polio among children in Gaza after more than 2 decades of its absence. Researchers are warning that the next outbreak could be far worse than COVID, because risks are multiplying all the time due to more travel, growing populations and industrial livestock farming, which increases the possibility of zoonotic diseases crossing over from animals to humans. The lessons of the last COVID pandemic haven't been learned, say scientists. In May, WHO talks on coming up with a global playbook to combat disease X were inconclusive. In fact, agreement on a draft for the world's first pandemic deal will be deferred till next year. The reasons? Bitter divisions among the 194 states in attendance. A repeat of the same squabbles that the COVID crisis triggered.
During the COVID-19 pandemic, we implemented solidarity mechanisms that didn't exist up until then. Vaccine doses, transfers, donations, initiatives for tests to roll out vaccines whenever they were available. However, we also saw the limits of this solidarity. When the richest countries were hit with the pandemic, they gave priority to their populations.
Some officials failed to agree on the efficacy of lockdowns and masking, arguing that the World Health Body had overstepped its mandate. In Europe, several scientists say that the lack of funding for drug research could block plans, which suggests the EU has not put in place lessons from the COVID era, forward planning and more investment. So are we on track to repeat those same mistakes when the next pandemic takes off?
Well, let's meet our guests. Joining us from Geneva is Dr. Margaret Harris. She's a spokesperson for the World Health Organization. David Alexander is a professor of emergency planning and management. That's at University College London. He joins us from Tuscany in Italy. And in Derby in the UK, we have Professor Keith Neal, a public health doctor who has worked at the University of Nottingham. You're all very welcome to Roundtable. Margaret, I'll come to you first. We were told that a pandemic is a once-in-a-century event, so we can all kind of sleep easy at night, or can we?
No, we certainly can't. I'm not sure where this once-in-a-century event comes from, because in fact we've got quite a few pandemics running. We've had the HIV pandemic running since the 80s. We've had a cholera pandemic running since before then. A pandemic simply means an infectious disease that's creating more cases than expected in most regions of the world.
David, I see you nodding in agreement there. So we do need to be paying attention, and this is something we should be worrying about?
Yes, indeed. If we take non-seasonal influenza, well, of course, you could have a pandemic of seasonal influenza in as much as it is sometimes and often quite serious. But non-seasonal influenza has a return period of about 35 to 40 years. Now, that doesn't tell us anything about its lethality or infectiousness, but that could vary with any of the outbreaks that occur. So it's certainly not once in a century.
Keith, are we in danger of hyping up this talk about pandemics? The media love a scare story, and there's certain sections of the media that would love to see perhaps another outbreak to basically drive the news agenda.
That may be a news question. I think the question is, over the last 42 years, I don't think a single year has gone by without a new disease being recognised, which has spread significantly. And sometimes it's been 4 or 5. As Margaret mentioned, we've still got HIV, we've got cholera, we've got recurrent flu, we've had SARS, we've had SARS-2. I could go on, but I think you would want another question. I don't think we can hype it up in that sense, because the risk is genuinely real. I think what we need to do is manage the public and inform that we can actually do things about it, such as we did have lockdowns or new vaccines. It's not a total doom and gloom story. It's a one for positive action.
Margaret, I'll come to you, and I want to ask all of you this. What would you say the biggest risk coming for humanity is?
Well, the biggest risk is exactly what's already been mentioned, forgetting to worry. We're seeing spillovers from the animal kingdom to the human kingdom increasingly. But what we keep on doing is going into this cycle of panic and neglect. So panic, 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 while, as you say, the media or people are frightened of something, but neglecting to do the stuff that's going to stop us from having another experience like the COVID-19 experience we've gone through.
David, what's your take then? What do you think is the big issue we should be worrying about?
To be honest, I can't answer that, and that is despite trying very hard to do so. We have a number of foresight projects going on at present, and we believe very much in foresight, which is not about prediction. It's about trying to develop ideas of how things may progress in the future, let's say 30 years, 40 years time. And things do change very greatly. There are at least 17 different major risks that could become the dominant one. And that is why it is very hard to say so. But I would be very concerned about the possibility of a disease that is highly lethal and highly infectious, and that's spreading around the world, which it will be very easy for that to happen, I'm sure.
Keith, give us your opinion on what we should be looking at next.
I think I used to be most worried about a sort of an aerosolized airborne Ebola. But after COVID, I'm less worried about that because it is so drastic, we would take immediate precautions. I think it's someone with a lesser degree of lethality, between say 5 or 10%, that spread like measles would be very difficult to control. If we really had airborne Ebola, people would completely lock down. We could really control it, and we would have to take drastic action. It's that slightly leveled down, which is less easy. It's still easy to control, but the will to keep it doing politically and socially might be a lot less.
Margaret, how thankful should we be that Ebola hasn't spread outside of the continent of Africa? I mean, it is a truly horrendous disease.
Well, indeed, it actually has spread outside Ebola. We saw a limited outbreak in the USA, and that should have given us, as a world, a bit of a warning. It wasn't identified when a person came in with Ebola into a hospital in the USA because they weren't expecting to see it. So anything can spread if you're not paying attention, if you're not prepared, if you don't think it's going to happen in my place. And I don't mean that we have to be constantly in panic, but I think that was a very good point that was made. When something is less lethal, governments are less frightened of it and therefore don't really want to put in the big financial commitment, social commitment to stop it. So that's why we at WHO say you've got to get those things in place before something arrives, not when it arrives.
David, in your experience the last couple of years in particular, how prepared are governments now for the next pandemic, given all of the learning from COVID? I guess some countries learned better than others.
Well, we can't say that there isn't research, because in the first 9 months of COVID, 75,000 scientific papers were published in the mainstream scientific literature and 1,200 books in English. So we've got a vast amount of information because, of course, since then it has continued to increase to the point where the amount of research is now virtually uncountable. So we've got the information. We're dealing, however, with a situation which is, if not unique, rather particular, because it is half a medical, virological, epidemiological problem and half a sociological, economic and psychological problem. And all of that has to be dealt with. So in some respects, the biggest risk that we face is political decision making. And the trouble is that if you look at just about any kind of disaster, governments tend to face up to it when it happens and then shy away from it when we have to spend money on mitigating the risk, reducing the likelihood and all of that. And I think this is what they are going to do or have been doing with the risk of a major pandemic. And that really is how it is most of the time, which is partly understandable because governments have a huge variety of calls upon limited resources. But on the other hand, we have to be very serious and very grown up about the risk of a major disaster, or indeed a set of major disasters.
Keith, I want to ask you about the UK's initial response to COVID, because Boris Johnson was famously Prime Minister at the time, and he famously didn't go to the first 5 emergency COBRA meetings of all the top brass in the United Kingdom. He didn't even deem it worthy of his attention at the time, and we saw how that panned out. What do you think governments will have learned from the initial response to COVID at the time?
I think the one thing we need to learn, and this was the same lesson from swine flu, is we need to be able to ramp up testing capacity for the disease. Once we've sequenced a virus, we can create the primers for PCR testing. But the big problem with COVID, as far as I can see, and when I worked through swine flu, is that nobody understood just how widespread it was because we had an inadequate testing capacity. In the sense that if we can actually test it, find it, and know how big it is, it's going to be much easier to act.
Margaret, I just want to come to you. What do you think governments should be doing now? We're in, there is a lull. All of the talk of pandemics has gone away mostly, and a lot of governments are working on rebuilding growth in their economies, getting people back to work and building back from COVID. Do you think there's a danger that they just kind of forget it, consign it to history, and not work on planning to make sure that the response is there? God forbid something happens again.
There is that danger. Now, the good thing is there is actually something called the Pandemic Accord being negotiated right now. We actually wanted it to be in place by May of this year. There are some sticking points. It essentially focuses on 3 things. Governance. We've talked a lot about leadership, getting that leadership really functioning, but systems as well. And one of the critical things is building up your health workforce capacity. We've already heard mention of testing. It's great if you know what the virus is, but indeed, if you don't have the systems for testing it, so what? You don't know someone's got a fever if you don't take a temperature. And also having your hospitals ready. Now, that means you actually have to be over capacity. It means you actually have to have more health workers than maybe you think you need in peacetime. But that's not a bad thing for the rest of your health system. It's quite good to have some fat in your system. And the other thing, of course, is financing. Really putting your money into health emergency preparedness. And these are things governments don't like doing. Health has been very much the poor child behind the door. I hate to say the red-headed child because I'm red-headed, but health has been that, and often the health minister isn't even in the inner cabinet in many countries. But COVID should have taught us this lesson. A tiny little virus can what can lay us low, destroy our economic systems, put us into social turmoil. So let's take health seriously.
David, I just want to come to you. Mpox has had a lot of coverage in the last few weeks in Europe. A case was detected in Sweden. Should we be getting very concerned about that, do you think?
Well, I'm not a virologist or much of an epidemiologist, so I couldn't really tell you medically. But what I do think is that we need to have good civil protection systems that very roundly embrace health. It's remarkable how often health is left out of them or is minimized. And a good emergency planning setup and good emergency management can save billions in money and tens of thousands of lives. It is therefore very much worthwhile having that and having a system that is not merely good on paper, but is well connected to the resources. The purpose of emergency planning is to organize our resources in the best possible way. One of the most fundamental things that government has to do is to protect the citizen as governments should. If you look at the situation in the UK, the civil protection system is a bowl of spaghetti. And those are the words used by Hugo Keith, King's Counsel, in the COVID inquiry in the UK. When we looked at the setup for the system, we found that there were numerous equivocacies in it. There were numerous areas where no one was quite sure who was in charge or who was responsible for some very fundamental things. And the whole thing was simply too complex, too unwieldy, too over-centralized. So what in fact we need to do is to prepare, but not merely at the national level. We need to be prepared at the regional or provincial level and the local level, very much so.
Keith, I just want to come to you on Mpox. What do you think of the threat to the wider public posed by that virus?
I think it depends on, we've already had Mpox clade 2, which is the less severe form across Europe. And although it spread rapidly, unfortunately, it didn't make any great problems because they're largely healthy people. Also, many of these people are in touch with healthcare services and could get vaccine quickly to the high-risk groups. Clade 1A and Clade 1B are a bit of an unknown quantity because it's difficult to know what the spread is likely to be, because they appear to be, Clade 1 seems to be zoonotic to children, Clade 1B is more personal contact. Also, we don't know about the severity, so I think we have to be very cautious. One advantage with monkeypox compared to COVID is so you have to be symptomatic before you can really spread it. So you haven't got this asymptomatic 2 days where you could spread it. The lesions are actually quite typical in the majority of cases, and we know how long it is. We do have a small supply of a vaccine for it, but this can be ramped up if necessary. So I think it's watch this space, and it's one of those, really, we don't know what's going to happen, but we are reasonably well informed should it spread. It's whether we can deliver the capacity quick enough.
Margaret, I've seen headlines about something called AMR, antimicrobial resistance, predictions that this could cause 10 million deaths a year by 2050, which would be more than cancer and diabetes combined. How concerned should we be about AMR?
Very, very concerned. And I'm really glad you raised it, because this is something that we have been, again, not just WHO, but the United Nations has made it an area of very big concern. And yet it gets worse and worse. And essentially, all the things that we do medically, your surgery, your standard procedures, your obstetrics, many of them do rely on the backup of working antibiotics. Even a simple throat infection, if it turns out to be a bacterial infection that responds to antibiotics, is one that will be stopped. But if not responsive to antibiotics, can become septicemia. And these things happened before we had antibiotics. None of us have been in the world before antibiotics. So none of us have seen what a world without antibiotics looks like. But any of the major surgeries you just couldn't do if you didn't have the antibiotic cover, because those people would go into, or there would be a great risk that they would suffer severe infection. So it's indeed one of the greatest health threats, and it's one of the least, it's one of the most neglected health threats by the wider public. It's one of the least well known. It's a really silent epidemic.
David, what's your view on the general public if they were told to lock down again, restrictions on movement? God forbid there ever was another pandemic. I mean, will people comply next time?
I fear the answer to that is incredibly complex. And one reason for that is the role of false or fake news, fake information, and so on, or beliefs that are scientifically unsustainable and so on. For example, when we do have a vaccine, we need everyone to be vaccinated because that is not merely personal protection, it's protection of society as a whole. It's a means of stopping the spread of the disease. So, in fact, if we have large numbers of people who refuse to be vaccinated or refuse to take reasonable measures, then we're going to have problems. A lot does depend upon the social welfare component of this, which is very expensive, and whether governments are willing to supply that. We also have a question of things like surge capacity in hospitals and in medical institutions generally. We saw that improvised, sometimes successfully, often unsuccessfully during COVID. Do we have enough surge capacity if there is another pandemic? So there are many different interacting factors here. Yes, at the moment we have the memory of COVID and what it did and what needed to be done about it, and that will gradually fade. If we then have another pandemic that requires drastic social measures, the key to that, or the two keys, are the quality of official communication and trust in our leadership. This we often did not have, not merely in Britain, but in many parts of the world. And so we really do need that desperately if we're going to have a pandemic and if we're going to have to ask people to make sacrifices, which in many instances are very, very deep sacrifices, but nevertheless necessary.
Margaret, I just want to come back to you on pandemic accord, which you mentioned earlier on. I mean, as we look ahead to 2025, this year, 2024 will speed up now as we head towards the new year. What would you like to see achieved?
Well, certainly, I would love to see the pandemic accord agreed and signed up to. And we've got the teams are working into intergovernmental negotiating body that's putting this together. Already met in July in the middle of the European holidays, and they're continuing to work. So that would be great. I'd also like to see genuine commitment in every nation to look to building up their health system and understanding and appreciating their health workforce. The health workforce around the world is millions of people short. So what I'd love to see is true appreciation, not just clapping during COVID, but true appreciation of the health workforce and building up the nursing staff, the ambulance staff, all the paramedical staff as well as the medical staff, because they're the people who stand between us and disaster.
That's a good point, David, isn't it? I mean, the sun might be shining now, but we need to fix the roof.
Well, that is the dilemma of disaster preparedness generally. From my perspective, what we need are good, robust, and above all, realistic emergency plans. Realistic in this case means that they are tied to resources. In other words, that when they are put into effect, if they need to be, these plans will work. What we found with COVID was there was a burst of planning. We had the full scenario for a major viral pandemic built up over the period 2003 to 2009. We had a flurry of emergency planning at the national level led by WHO from 2005 until about 2012. From 2013, interest simply declined and it went over to other risks. For example, in Britain, it was the question of a hard Brexit. It was also counter-terrorism, whatever it was. But despite the fact that for 12 years, the National Risk Register in Britain, which is often used as a model by other countries, incidentally, had pandemic influenza or some kind of pandemic as the top risk in it. In other words, the most likely and the most potentially devastating. When it came to the activation of plans, the utilization of plans, they were simply missing or inadequate, and they were not tied to available resources. We cannot afford for that to happen because we've already found a number of viruses which could develop into the next source of a pandemic.
David, Margaret, and Keith, thank you all so much for your insight on that. Remember, you can see more discussion and debate on our YouTube channel. Just search for Roundtable TRT World. And if you like what you see there, please do hit that subscribe button. But for now, from me, Enda Brady, and all of the team here, goodbye and thank you for watching.